Good evening, ladies and gentlemen, dear colleagues. Welcome to APSR webinar entitled Update of COVID-19 Situation in Asian Pacific Region. Only recently, WHO Director General warned that the worst is yet ahead of us in the coronavirus pandemic, raising new alarm bells about the pandemic, just as many countries are beginning to ease restrictive measures. Actually, infected patients have exceeded 2.5 million in the whole world, and almost 170,000 people have died of this disease. Some reports says among infected persons, nearly 10% are unfortunately healthcare workers. Principal battlefield appears to shift to Western countries. However, still the number of patients is increasing in most countries, areas in Asian Pacific region. Under limited manpower and infrastructure, health professionals, including chest physicians, are working so hard. I hope this webinar we can share awareness, discovery, and ingenious device, which should be helpful for our battle against this virus. Thank you very much for joining us. And I am Yoichi Nakanishi, President of the APSR, and I would say this program was arranged by great support and help by Dr. Kwon Fong, immediate past President of the APSR, and Dr. David Lam, Secretary General with the APSR, and also Dr. Arata Azuma, the Chairman of the Education Committee. So, Dr. Azuma, could you introduce yourself? Dr. Azuma, can you hear me?
Yes. Hi.
So please introduce yourself.
Yes. Thank you for joining us, everyone, for participant and all audience. We'd like to share the information and update of COVID-19 today. Thank you very much.
Okay. So before the beginning of this webinar, I would like to introduce the presenter of this webinar. First presenter is Dr. Elina Burhan, Indonesia. She is APSR Tuberculosis Assembly Head and a Chairman of Indonesian Respiratory Society, Jakarta branch, and now working as a pulmonologist at Persahabatan General Hospital, Medical Faculty, University of Indonesia. And second presenter is Dr. Kuo Chin Kao from Taiwan. He is a APSR Critical Care Medicine Assembly Deputy Head and also the Deputy President of the Taiwan Society of Critical Care Medicine. And third is Dr. Tan Jin Liang from Malaysia. He is a consultant chest physician, respiratory medicine division, Department of Medicine, University of Malaya Medical Center, Kuala Lumpur. And fourth, Dr. Kondekar Mustaq Adnan, Bangladesh. He is a consultant of the respiratory medicine in Central Pole Hospital. And anchor, final presenter is Dr. Dinesh Dasanyake from Sri Lanka. He is a consultant respiratory physician of the District General Hospital, Polonnaruwa. Okay. Anyway, I would express a sincere appreciation to all the presenters here. Thank you very much. So let me start. The first presenter, Dr. Burhan, please. Please start just the presentation.
Thank you, Professor Nakanishi, and also Professor Azuma. I would like to present my presentation regarding the situation of Indonesia COVID-19 situation. So Indonesia is a density population with more than 270 million people with 34 provinces. And our first COVID-19 case in Indonesia was announced in Jakarta on March 2nd, 2020. Those were mother and daughter. And during that time, then we had clusters. The first one is an imported cluster consisting of 2 cases with the history of contact with foreign people. And then we also had this cluster from Diamond Princess cruise. 2 Indonesian cruise was also positive. And 9 was hospitalized in Japan and 1 was hospitalized in Jakarta. And then the last cluster was the World Dream Cruise. We did quarantine them all in an island next to Jakarta. And current situation, there is we do not really focus on cluster since this is already a community transmission. So this is the situation in Indonesia right now, that we had more than 200,000 people as suspected cases, and out of those being tested, we have 7,135 confirmed cases, and more than 5,000 of them being hospitalized, meaning that these are actually the moderate and also severe cases. And we are now a bit happy that the increasing number of recovered patients, which was already 842, but yes, we have also high number of death rate, is around 8 point something %. So we have now more than 600 patients that died of this case. And then this slide shows that the cases is exponentially increasing after March 16. And even now it's not yet declining, it's still in increasing numbers day by day. And this is the report on daily new cases day by day. You can see here that sometimes there is a bit trend that in 1 or 2 days there is less people being confirmed as positive cases, but then the day after that day is increasing again. Yeah. And we can see here also the daily new death in Indonesia. We have a very high number in April 15 and also April 18, but April 20 was a bit less, not a bit less, more than 50%. Yeah. And this is the report from my hospital, Persahabatan Hospital, reside in Jakarta. Persahabatan Hospital has there is a very big hospital, and we start receiving patients starting from March 4th, and up until now we already have total 386 patients that being inpatient, but around more than 200 were eventually yield positive from the PCR result, and the rest are just suspect, and some of them were actually not COVID. And we do have also some comorbidity. If you see here that out of those 60, more than 60 patients that died, the most comorbidity was hypertension, followed by diabetes mellitus, and then cardiovascular disease. And there is also some geriatric patient, elderly patient, and some patient having chronic respiratory disease, and then also there are some with renal disease, obesity, and neurologic disease. And yes, there are very few with liver disease. Only one patient with malignancy, but very unfortunately, we have one infant patient. I think he was 3 months old. And if you want to know what regimen that been using in Indonesia, I think we do all know that there is no specific drug against this SARS-CoV-2, but there are sites who give the regimen such as chloroquine phosphate 500 milligram twice daily for 5 days, and combined with azithromycin 500 milligram single dose. And if there is antiviral drug available in the hospital, we choose either oseltamivir or Tamiflu. If there is no Tamiflu, then we have a option, Avigan. I think that was donated from Japan, but only several hospital that can assess that Avigan. We also give a vitamin, but in our hospital we choose to give vitamin C, and also there are some other symptomatic treatment. I think I spent already 7 minutes for my presentation. Thank you very much for your attention.
Okay, thank you, Dr. Barham. Very impressive and nice presentation. I was very surprised. The thing is very, very serious in your country. And regarding with the, may I have a question about treatment?
Yes, please.
You use chloroquine, azithromycin, Avigan, and Tamiflu. And for me, the effective azithromycin was a first time for me to hear about it. How would the impression of effectiveness or effects of this drug? Do you feel a little bit effective or no?
We have not yet finished evaluating this regimen, but we heard that from other country combining azithromycin and chloroquine or hydroxychloroquine gave a very good result. But very recently that I read a journal from Brazil saying that hydroxychloroquine was not effective. So very different in different countries. So and people gave a variety of a regimen. There is some place in Indonesia they give lopinavir plus ritonavir or aluvia, and we probably in very soon will also trying to give remdesivir, but it is still in our Indonesian FDA approval, so we do not have yet. But there is also some discussion of going on in several sites that they are trying to do this plasma concentration. And even in our hospital, we are already finished, finalized the proposal to do this as a research, but not as a services.
Okay, thank you very
And
much.
some
Mhm.
of my colleague and together with me, we are going also to apply this stem cell.
Stem cell.
Yeah, but still this is as a research, not as a service, a regular or standard treatment.
Okay, treatment is a very important issue. However, still everything is confusing. So I hope that some result of clinical trial to be open. I hope the Western countries, some trials have already finished, and maybe in near future, some more data will be available. And another question is, do you have enough medical supplies such as surgical mask, N95, PPE, or anything? How about it?
Those are things that are very, very difficult to find now. I think that is also happen in many countries. But yeah, so our hospital got donation not only from the government, or not a donation from government, they have to do it, but we got donation also from community, society, and institution, but we are still worried about this personal protection equipment since the increasing number of cases are still coming. So yes, if government of Japan would like to donate to us, please donate N95 mask.
Yeah. For most countries, thing is very short. Yeah, but okay, I'll negotiate it. Okay. Thank you very much. Okay, so let us move on to our next presenter, Dr. Kao from Taiwan. Please start your presentation.
Okay. Can you hear me?
Yep.
Okay. I'm nothing to disclose about the conflict of interest. I'm Guo Jinggao from Chang'e Memorial Hospital, Taiwan. Today I will show some experience about the COVID-19 from Taiwan. This slide gives some information about the COVID-19 cases reported in the whole world. As we know, on the January 23rd, the Wuhan city is locked down. So in the January and the February, lots of cases reported from China. However, in March, a lot of cases reported from Asia, European, and the USA. And you can see a lot of patients reported. Until yesterday, about 2.5 million cases reported, and with the mortality rate about 6.8%. And this slide shows the newly confirmed case after 100 cases from the different country. You can see the trend of the USA, Spain, Germany, and Italy. It looks the smooth or flattened or the decrease the case. However, in Singapore and Japan, you can see the trend is still going up and the increase. In Hong Kong and Taiwan, the case is relative, is not so many. And this slide showed how many, what's the important control measures in Taiwan to prevent the community transmission of COVID-19. And you can see on the January 20th, the Taiwan government activated the Central Epidemiological Command Center. And later states, we implemented home quarantine for travelers from many cities or countries. And we also applied a travel restriction to many countries and the area, and extend to the many countries later. And you can see on the February 12th, and we enhanced the surveillance and extended the home quarantine to travel from South Korea and many countries later. So in the March, you can see we increased the travel alert from level 1 even to the level 3 from the different country, and finally on the March 20th, we increased the travel alert level 3 to the whole world. This is the many important control measure in Taiwan. And also you can see most of the cases are imported from other countries. Only few cases, you can see the yellow bar, were locally acquired. And in the only until to the April 16, we have the case number was 395. And also is, you can see the most of cases are imported and the only few cases are locally acquired. And how about the characteristic of these 395 patients? You can see most patients are female, and these patients are quite young. The median age around 33, and only 50% patient was 60 years old. Also, most patient was imported from other countries. The most common, the number one is the United States, followed by the UK. And also, how about the distribution and the instance by age? You can see the distribution by age. The most common is 20 to 29 years old. It's the same by instance. Also, the 20 to 29 patient is the most common. So how about the severity and the prognosis? You can see around the 70% patient is mild illness, and the 22% with mild pneumonia, and the only 7.6% patient have the severe pneumonia or ARDS. In terms of the mortality, you can see only 1.5% mortality rate. Only 6% died in these 395 patients. So how to respond to the COVID-19 in Taiwan? In the UK, if you want to see that in detail, you can look at JAMA published on the March 3 in this article. We use many methods, including the big data analysis, new technology, and the proactive testing. First, we have to recognize the crisis, followed by the managing the crisis. We use the border control, case identification, and the containment. Also, we use the resource allocations. I think the most important is to communicate with the public. So we use the reassure and educate the public. Also, we fight the misinformation. And then on the January 23rd, we established the Central Epidemic Command Center, CECC. The CECC has conducted daily press briefings on PM 2 o'clock, and which is chaired by the commander to release COVID-19 related information to the public. Mass media, such television, poster, and the radio, as well as the social media, such as Facebook, Line, Twitter, have also been extensively used for public education. And this announcement included social distance measures, when to wear a mask, and the importance of hand washing to prevent community transmission. However, we still have a challenge. Just a couple of days ago, on April 19, we have 21 patient confirmed case from a Navy ship. So we still have to work hard to fight the COVID-19, this very hard work. And thank you very much for your attention.
Okay, thank you, Dr. Kao. Taiwan, in case of Taiwan, this is the most successful case in the world. So I was really impressed with your presentation and also the system of Taiwan. And I have, I got a question from the audience. Question, how is your experience with treating acute kidney injury? Which dialysis modality, for example, CRRT, should be the continuous renal replacement therapy are preferred? This is a question. How about it?
And for the COVID-19, your patient with acute kidney injury needed renal replacement therapy. In terms of the prevention or protection our healthcare worker, I think you have to choose the intermittent hemodialysis first. And if the patient's condition, the hemodynamic is stable, I think there's no problem. We can choose the intermittent hemodialysis. However, if the patient's hemodynamic is not so stable, for example, maybe the systolic blood pressure around 80 to 100 millimercury, maybe you can choose one of the intermittent hemodialysis, such as the extended daily hemodialysis. That means you can apply the hemodialysis every day. So you can prolong the duration of the dialysis time and keep the adequate blood pressure. Of course, if the patient's hemodynamic is very unstable, you have to choose the continuous renal replacement therapy. That's my opinion. Thank you.
Thank you. So anyway, you mean it all depends on the condition of patients, okay?
Yes.
And another question that, what is the renal pathophysiology in the real pathophysiology in the COVID-19 disease process? It might be a little bit difficult question. How about your comments?
Yes, that's a very difficult question. But I searched one paper from the critical care and the intensive medicine by the Gattinoni from Italy. He posed one hypothesis to describe the pathophysiology of COVID-19 pneumonia. He differentiated two kinds of the phenotype, the type 1 and the type 2. And the type 1 also called the low type. That means this patient will have the vessel pressure. Vessel pressure means the loss of the vessel constriction when hypoxemia. So the characteristics were low elastance with high compliance, low shunt, low lung weight, low recruitability, and the poor response to the PEEP. However, in the other group, in the other phenotype, is the H type or type 2. And this patient characteristic will be high elastance with low compliance, and high shunting, high lung weight, high recruitability, and also response to PEEP. So this type 2 is very similar to the traditional severe ARDS. So maybe you can use the many modality to treat the ARDS, such as the low tidal volume, higher PEEP, recruitment maneuver, even the inhaled NO or prone position of the ECMO for this type 2 COVID-19 pneumonia. Okay, that's so until now, this is still a hypothesis. So, yeah, we need more information. Yeah.
Okay, thank you. Very suggestive information. Anyway, if we can make clear the pathophysiology and or we classify the subtype, we would be able to reach the more suitable, more fitable treatment modality. Okay.
Yes.
Thank you very much.
You are welcome.
Okay, then we'd like to move on to the next presenter. Next presenter is Dr. Tan from Malaysia. Dr. Tan, please.
Okay, good evening, everyone. I'm Dr. Tan from Malaysia. Thank you, APSR, for giving this opportunity to me to share the condition regarding COVID-19 in Malaysia. Okay, so on March 11, WHO announced that COVID-19 had become a pandemic. 1 week later, on March 18, our government started this movement control order during this movement control order, we are required to stay at home and only allowed to travel out to get our daily essentials. So there are a lot of roadblocks everywhere, and people are forbidden to go out freely actually. And those who violated this order will be fined or even imprisoned actually. So this movement control order was actually further extended another 2 weeks in April, and now we are in the 6 week period, which is movement control order 3. During the second phase, the government also introduced this enhanced movement control order, whereby those areas with a lot of cases of COVID-19 will be put on total lockdown, meaning no movement allowed in this area at all. So all the streets, you can see all those pictures here in KL, in Kuala Lumpur, all the streets are actually relatively quite empty. So all the business actually have to be stopped at this period of time. So in Malaysia, just a bit briefly, how do we manage all these COVID-19 patients? We admit all those who have confirmed COVID-19 positive patient from the RT-PCR testing, whether they are mild symptomatic or whether they are actually asymptomatic. As long as their COVID-19 is positive, we'll admit them to the designated COVID hospital and will be managed mainly by the infectious disease physician. But in our center, in University of Malaya Medical Center, it's a joint management between CHEST team and as well as the ID team. Those who are asymptomatic or mild symptom, usually we just on surveillance, we do not give them treatment. But those came with pneumonia, evidence of pneumonia on x-rays, or those high-risk population like those elderly patients or those with comorbidity, we tend to start them on some form of treatments earlier actually. So these are following list, these are the treatment that have been used in Malaysia, which include hydroxychloroquine, tocilizumab, Kaletra, recombinant interferon beta, low-dose metoprolol in some cases. For tocilizumab, which is the interleukin IL-6 inhibitor, we usually give it for patients with suspect cytokine storm. We look at CRP levels, the ferritin, as well as the clinical parameters. Let me just share one or two cases that we started this patient on tocilizumab. This first patient here, this is a 48 years old male, came at day 8 of illness, came with cough, shortness of breath for 3 days. He came in quite bad actually, quite hypoxic, 89% on high flow mask. He was immediately intubated in our emergency. And later on was admitted to ICU, was found to have a very severe myocarditis, acute renal failure with hepatitis. On the next day, after we got the CRP or the troponin I, we started on hydroxychloroquine, and also we give a dose of tocilizumab. You can see here, after the tocilizumab was given, the parameters actually came down very rapidly. You can see the X-ray on admission here is very diffuse lung changes. 3 days later, some of these changes almost gone. And he actually survived this. 4 days later, we managed to activate him into high flow nasal cannula, and he was eventually discharged 1 week later. Just to show you the second case, a 59 years old male came at day 8 illness as well, coughed for 1 week, shortness of breath for 5 days, came with actually saturation of 88% on nasal prong, not too bad, so he's not intubated, but he was admitted to ICU. This is his X-ray on admission. After we got the blood test, we also given him this hydroxychloroquine as well as tocilizumab because of very high ferritin and very high CRP. We managed to actually, he survived these episodes. We put him on high flow nasal cannula on the 1st of April. And 3 days later, we managed to take it off. And subsequently, another 3 days, he was discharged home. So in this case, just to show you, this patient actually avoided intubations, survived, do not need mechanical ventilation at all. So we just put him on high flow nasal cannula and he just go through these episodes. And what are the situation now in Malaysia? I think initially in March, some of the statisticians actually predicted our cases will peak somewhere in mid of April. But what is the situation now? You can see the graph here. We actually relatively getting more flatter now. Look at the cases that discharge, cases of active. You can see here, the patients, there are more discharges compared to those are actively treated in our hospital. And the cure rate now is actually approximately 61%. With patients that recovered more than those patients that's in active treatment. And in our populations, those who are getting this COVID-19 pneumonia are mostly male, and elderly and those with comorbids. Lastly, I think as our Director General of Health have mentioned, we have not won the war yet, but neither have we lost the war yet. Together, I think we can still flatten the curve. I think everybody just stay safe and thank you so much.
Okay, thank you, Dr. Tan. Very nice presentation, and things looks getting better. And I got a question from the audience. Question 1: may I have your comments or suggestion regarding with number 1, current post-COVID-19 follow-up, and number 2, monitoring of potential reinfection?
Currently, all our patients that discharged from hospital, we are giving them 3 months follow-up in our clinics just to monitor their lung functions. And those who have hepatitis will just monitor their liver functions just to see whether there's any changes. Currently, we do not check for reinfection, but those who discharge, we do give them some advice what to look for, what are the signs that they should pay attention to. If let's say they develop the symptom back, what they should do. And we actually encourage them to actually strictly stay at home, keep social distancing, do hand hygiene regularly.
And then do you experience some case with reinfection?
So far, no, not in Malaysia.
Okay.
We don't have that yet.
And another question is, how about infection rates in healthcare workers?
Okay, I have some statistics. Maybe let me just share some slides. Okay, so as of 10th of April, we have about 224 healthcare workers that was reported to be positive for COVID. But for the investigation so far, none of these cases actually caught the infection from the COVID patient itself. Means when they are on duty in the COVID ward or ICU, none of them actually got it from those patients in the hospital. Where do they get from? About 67% of them get it from community, meaning they was attending some in close contact with a positive case that they are not sure of. And 18% of them actually got it from patients that come in with SARI. Some of our patients, they do not disclose their conditions, where's their travel history to the doctors. So when they are intubated, then only we do the test, then they found to be COVID. So they was exposed to these patients without a proper PPE, so hence was infected. Compared to in our hospital, in my center, we have 17 healthcare workers that was infected. 30% was from community. Another 70% actually infected from handling patient of unknown status. So you can see if the patient don't tell us truthfully what happened to them, they can actually, they don't wear proper PPE. Some of these patients, healthcare workers might get the COVID infection. But so far, as of our hospital, none of the healthcare workers that on duty in the ward get this infection actually.
Okay, thank you. It's a very, very important information. So anyway, the most serious or dangerous factor is not inside, but outside. Yes. Okay. Okay, thank you very much, Dr. Tan. Very nice presentation.
Thank you.
Okay, so we'd like to move on to the next presenter, Dr. Adnan, Bangladesh. Dr. Adnan, please. Dr. Adnan?
Afternoon.
Okay. No?
Good afternoon. I am Dr. Khandakar Mustaq Adnan, working as a consultant in the Central Police Hospital of Bangladesh, in the capital of Dhaka, and also as an executive member of Bangladesh Lung Foundation. I want to I start my presentation.
Yes, please.
Yeah. Now, in our country, the first case was discovered on the 8th of March. Worker working in Italy, returning back to his own country, and he was first tested positive as COVID-19. Then, still now on, we are in the 6th week of our infection, and now we have total 3,772 cases, among which 120 patient has been died, and total cured number of patient is 92, and total test which is performed is 32,674. You all know that our country is a very highly densely populated country. 18 crore people live in only 1,70,000 square kilometer area, and this total map of Bangladesh, geographical map, shown that the total country is divided in 64 districts, and 44 districts have already been affected by COVID-19. And in the capital city of Dhaka, we have 12 hotspots, where each hotspot act as an highly highly transmissible cases, and more than 50 cases in each hotspots. Now this is the curve showing that we have started testing from March 8, but in the initial stage of the phase, the case number is very much low, but starting from April 7, the case number is increasing, and today on the April 19, there are 492 cases, and today the recent update is the new number of cases is 390, and total death in the last 24 hours is 10. The newly cured is only 5 patients has been cured, and the RT-PCR test has been done 2,309. This is the date-wise confirmation of the cases, that you can see that from the 4th of April, the surge has been, the curve has been in linear curve is uprising, and in April 20 it's 492. Initially, the number of tests was very low in our country due to some financial and logistic support. Whenever the number of tests has been increased, the total number of case is also increasing. This is the treatment flow, overview of a treatment flow. You will be very sorry to know that in 18 crore of people or population of country, we have only 50,000 doctors, 25,000 works in government sector, and 25,000 works in the private sector, and only 10 hospitals has been set up by the government for treatment of this COVID-19 patients. Among 3,772 cases, 1,100 patients has already been admitted in the hospital, among which 67 patients are in ICU. And in my hospital, total 148 patients has been admitted, among which 7 patients are still in ICU. This is the current scenario where we can show, you can see that 600 physicians has been involved in the treatment of COVID-19 cases, and this is the picture showing that the number of isolation beds has been already set up, in which the suspect cases has been isolated, and the total lockdown situation had been started from 25th of March, and this lockdown is not appropriately applied in the people, because more than 35% of the population live here from hand to mouth. They have to come out from their home to earn their livelihood. This is the we have also very much scarcity of the personal protective equipments. New study has been done by BRAC University James P. Grant School of Public Health on 18th of April. They showed that 25% of the doctors and nurses and around 60% of the supporting staff engaged in treating the COVID patients are yet to receive any personal protective equipments. Although the WHO recommends that PPE should be used once and then destroyed. And this has created a huge dilemma among the healthcare workers, how they would be able to use their equipment, and it also causes them great stress and anxiety. Till date, 170 doctors have been confirmed positive for corona patients. Most probably the cause are two. One is the lack of perfect PPE, standard PPE, and the other is lack of education. the executives of Bangladesh Lung Foundation, had already started philanthropically the supply of PP by our funding, external funding and other. And also we are creating a group to teach, educate the junior doctors about the perfect management of the COVID-19 patient by saving himself or herself. This is the age distribution of the reported confirmed cases. You can see by this graph that the pattern of involvement in the population is very opposite than what we have seen in other areas of the world. And here the 21 to 30 age group has been affected 21%, and 31 to 40 is 19%, and 41 to 50 is 15%. That means 21 to 40 age group is the highestly affected age group in COVID by Bangladesh. And these are the people who are engaged in earning for the family. And that's a huge dilemma arises, lives versus livelihood. What will they earn? They will earn the life or they will earn the livelihood. And the World Economic Forum shows that for Bangladesh, COVID-19 is a humanitarian crisis with public health dimension. If large-scale prolonged physical distancing is required, then government must find the way to mitigate the economic shock. And because the majority of the country will flow into the food insecurity within few weeks, the urban poor people who live off their daily wages will have to already has started skipping their meals. Thus, they will gradually enter into the vicious cycle of malnutrition. Also, in this horrendous situation, we have some good news also. Many NGOs and many foundation has come forward for helping these people. They are arranging funds to buy the PPEs, standard PPEs, and also the government has declared 2 months basic salary incentive for the healthcare workers and doctors. Local manufacturers are started commencing production of the PPEs and some mechanical ventilators, and UNHCR has started a 150-bed isolation and treatment center in Ukhia, Coxbazaar. You all know that we have a large number of Rohingya refugees from Myanmar, and still no case has been identified among them. It's a great news because if they would be affected by COVID-19, then they live such an congested area, large amount of population that people would have been affected by COVID-19 and huge death could have been occurred. Some non-government organization has come forward. Sajida Foundation has dedicated a 30-bed hospital in Naranganj. Naranganj is also close to Dhaka and hotspots for COVID-19.
Okay, thank you very much, Dr. Adnan. I'm really sorry to hear that 170 physician was infected with COVID-19, but I hope the more help, not only about government, but the organization will be reached to your country. And I have one question. When and how to use NIV in hypoxemic respiratory failure in COVID-19 patients? How about you?
We are depending upon data, the researches that has been going on our population. We still have not started any trial in our country. According to data, we are managing our patients in our hospital. I have already told that we have 67 patients in ICUs and 7 patients in my ICU also. And the method we are following, that we are starting with low flow nasal cannula. If that is not maintaining, we are going through high flow nasal cannula and CPAP. And if high flow nasal, when the patient in the ward, in the area where the high flow nasal cannula system is applied, the doctors and healthcare workers must have to wear an airborne PPE. That means high fitted N95 mask. Although the chance of transmission through high flow nasal cannula is very less, but different trials have been shown it. And we are not using BiPAP, we are using CPAP, because CPAP helps us in 2 ways. One is by using CPAP, we can easily titrate the FiO2 against the SpO2 of the patient. And another is we have to can easily monitor the tidal volume and the minute ventilation by using CPAP. And then if these 2 methods are not adequate, then we start awake position, prone positioning of the patient. And when the awake prone position is not effective, and we immediately do the FI2 requirement and ABG. If the PO to FI2 ratio is less than 300, we have to go through for the intubation.
Mm-hmm. Okay, thank you very much. Thank you. So then we move on to the last presenter, Dr. Dasanyake from Sri Lanka. So Dr. Dasanyake, please start your presentation.
Good evening. So, I'm Dr. Dinesh Dasanayake, consultant respiratory physician from Polonnaruwa. I'm going to give you an update on the situation in Sri Lanka. Before even the start of the epidemic here, actually, our government made this national task force on COVID-19. It was established on 26th February 2020. First imported case was reported in Sri Lanka on 27th February. This was a Chinese national who was traveling as a tourist. Since then, there had been air travel screening at the airport with restrictions, and quarantine for travelers from high-risk countries was imposed, and then quarantine centers were established in many places in Sri Lanka. Then first local case was reported on 11th March 2020, and then since then schools have been closed and public holiday and work from home began from 16th
Excuse me, Dr. Dasan.
and
Doctor, could you share your slide, please?
I hope you can see the slides now.
Yeah, we got it. Please.
Yeah, okay. So this is the first slide. So, so work from home began on 16th March, and inbound flights were cancelled on 17th March, and lockdown curfew was actually imposed on 19th March. Since then, the government had set up COVID isolation centers, about 18 throughout the country, and the testing capacity was expanded throughout the country. So this is today's report. So we have total cases of 321 patients at the moment, and 104 of them have recovered. And there were 7 deaths, and actually we haven't had any deaths for the last 10 days or so. And the case fatality rate is around 2.1%, so compared to some of the other countries. And active cases at the moment is 210, and there's 1 patient in ICU at the moment. The highest number of patients was from Colombo, the capital, was 110. And it's very interesting to know that most of the new patients, rather new cases, are asymptomatic contacts of previously found patients. They have no symptoms, but their tests were positive. And actually, last 24 hours, we have detected about 33 such cases, and only 2 symptomatic patients were found in the last 48 hours. And epidemiology unit has declared that their epidemic level is level 3, and there's no community spread at the moment, but there are community small clusters of cases occurring around the previously diagnosed patients in Colombo. So our treatment center is actually situated about 300 kilometers away from Colombo. This was set up because at the beginning, quarantine centers were put around Polonnaruwa area. So there were 2,660 people quarantined in these quarantine centers. Out of that 2,660, 89 was positive for COVID-19, and at the moment, total remaining quarantine are 970. Out of that 89 patients, 66 patients were treated in our center, and out of that 51.6% were females and 48.4% were males. And the average, the age of females was 42 and male was 37. The age is somewhat similar to some of the countries, but they are younger than the Wuhan population. Age range was from 9 years to 94 years. So when you take the travel and contact history, most of the patients, 51.5% of them were close contact of COVID positive patients returning from Italy. There was 31 patients returning from Italy, 46.9, and 1 returning from Qatar. And most importantly, out of all the cases, 62.1% were asymptomatic contacts of the previous patients, and only 37.9 patients had symptoms. So when you look at the symptoms, most of the patients had multiple symptoms, combining cough, fever, and headache. The commonest individual symptom was cough, followed by fever, headache, myalgia, sore throat, shortness of breath, diarrhea, and chest pain. We didn't have any patients presenting with neurological symptoms or eye symptoms. And most of our patients did not have any comorbidities. 56% did not have. The common comorbidities were diabetes, hypertension, and dyslipidemia, bronchial asthma, and combined multiple comorbidities. So when you look at the disease progression, out of symptomatic 25 patients, 20 of them were mild disease, and 4 patients had moderate disease with pneumonia, and only 1 patient progressed to ARDS requiring ICU admission and ventilation. The management protocols we used were for asymptomatic contacts and mild disease, we used HCQ, and symptomatic management and observation was used. For moderate disease, we use HCQ plus antibiotics for community-acquired pneumonia and observation. And the discharge criteria we used for fever and symptom-free for 72 hours, and 2 consecutive PCR done after 14 days negative. And repeat PCR was done on 14th day, and if negative, a third PCR on 48 hours after the second one. If both are negative, we send them for home quarantine. But 5 of our patients had positive PCR even after 14 days. So 1 patient had severe disease. This is a 44-year-old male who was a smoker, history of bronchial asthma during childhood. He was returning from Italy. He came with fever and myalgia and cough, and had ongoing fever, and deteriorated on day 6. He developed respiratory failure, and he had to be intubated. He was managed with HCQ, convalescent plasma, and broad spectrum antibiotics. He received a single dose of tocilizumab and ventilated for 8 days, but he died of severe respiratory failure. At the moment, currently we have 43 active cases, and 22 have been discharged, and 1 death, leading to 1.4% death rate, which is lower than many other countries in the world. But we have 4 modes of like isolation and quarantines, helping us to combat the epidemic at the moment. Quarantine centers, home quarantine, isolation centers, and as well as keeping patients in the wards and hospital itself is going to help the epidemic at the moment. So that's the current status in Sri Lanka at the moment.
Okay, thank you very much, Dr. Dinesh Disanyake. In Sri Lanka, still the shoreline protection or operation is effective, I feel. So anyway, I hope the thing is getting better. And I have one question. What is the place of steroid and plasma in COVID?
Yeah, for both of these treatments, there are no randomized controlled trials at the moment. I think take the steroid as per se. There are case series which are published in non-peer-reviewed journals, but which have shown there's reduced duration of supplemental oxygen and chest X-ray improvement in some of the cohorts in China. And there is indirect evidence from other studies as well and the past experience. However, in viral pneumonia without ARDS, steroids have shown more harm and increased mortality. And it also has shown that increased viral shedding on studies done during the MERS epidemic. So, however, there's a retrospective cohort analysis done in China, which has shown that in patients with COVID-19 plus ARDS, there's a risk of, reduced mortality if you use methylprednisolone. So, there's a weak recommendation of using methylprednisolone or steroids for patients with COVID-19 plus ARDS for a short course and a short duration of time. The methylprednisolone doses they have used is 1 milligram per kg per day for 5 to 7 days. And if there are separate indications for steroids like bromphyllasma, COPD exacerbation, then of course you can use, but it's not recommended for routine use. Similar with convalescent plasma, there are no randomized control trials, but meta-analysis on viral pneumonias in the past have shown that reduced mortality with convalescent plasma. That's why it was tried. But studies on MERS and influenza, there were no convincing evidence for increased mortality. There's no evidence, no data for efficacy and safety on this treatment as well. But there are case series in China on COVID patients published in JAMA, where they have used convalescent plasma and they have given 5 patients, and they have shown that there's reduced viral load and increased antibody level at day 28. So there's a weak recommendation again. We can use this not for routine use, but may use in severe life-threatening COVID, but they don't have to be 14 days post-PCR negative, and he should be asymptomatic for 28 days and negative HLA, and he should have a neutralizing antibody of more than 1 over 160 fetal. So those are the cases. With the developing evidence, this might change, but the current evidence, those are the recommendations.
Okay, thank you very much. Thank you, Dr. Denis Sanyake. Okay, thank you for excellent and informative presentation to all the presenter. And Professor Azma, could you please summarize this webinar?
Yes, thank you. Thank you very much for all participants. And on behalf of your society, very enthusiastic discussion. I briefly summarize this conference. First of all, in some country, initial success in fighting against the COVID-19, but most of others, foremost important would be engagement of public observing healthcare, measuring healthcare measures like wearing surgical mask and hand hygiene and social distance. This is a very basic, important things in the society. Communication and collaboration at multiple level. A government and society. Sorry. Can you hear me? Yeah. It's okay now?
Yeah, I can hear you.
Okay. Communication and the collaboration at the multiple level, the government and the society and the community level. All of these are very important in the social public health. And healthcare professional is also important things. Next slide. But I think it's a very most important things medical problem. Somebody mentioned pathology of the COVID-19 is nobody knows, still nobody knows. So investigation of the pathology of the COVID-19 is very important things. There is a two-phase respiratory condition might be rapidly progressive and fatal patient. This is one. And the second thing is, most of patient COVID positive, but the silent and mild disease. This is very problem in the society. So one of the most important targets therapy is a reduction of severe and fatal condition. Dr. Kao mentioned the hemodialysis possibility, and Dr. Tan mentioned the cytokine storm removing possibility in the future problem. So we in Japan is also we try to possibility of a blood purification before ECMO. In the future, we try to reduce the risk of mortality. So the purpose of the overcoming this virus. We would like to share the information of COVID-19 management, leading to win the fight against the virus. So thank you very much for all participants on this conference. I would like to close the session. In the future, next week, we would like to, next meeting, it's okay to keep in touch with us.